Hi, and welcome to our next case, which is inflammatory bowel. Now, let's look at this case. 24-year-old female comes to the office, diarrhea, sometimes blood, weight loss, 2 weeks, stool culture, ovum parasites, C. diff, toxin are all negative. Now, you must first exclude infection before you can go to inflammatory bowel. Got to exclude an infection first. Now, most ovum parasite things are not going to show you an organism that will have blood in it, with the exception of Entamoeba histolytica. On the other hand, you could have Salmonella in the stool, except Salmonella should grow on that culture. Giardiasis never gives blood. Besides that, on multiple stool ovum parasite exams, even though, you ready? One stool ELISA should be just as sensitive or more than 3 ovum parasite exams, one stool ELISA. But you don't get blood from giardiasis. Celiac disease also, no blood. But for celiac disease, we should be looking for floating, flying, frothy, oily, greasy stool. Because the fat's malabsorbed and it stays in your colon and it ferments and it rots. And it's like having a stool-flavored yogurt coming out of your rectum. Tasty. However, you should get prominent weight loss because you're malabsorbing all the fat, man. Viral infections don't give blood. The other thing is viruses don't go on for 2 weeks. And that's why this is more likely to be inflammatory bowel. However, you couldn't say it without doing the colonoscopy or sigmoidoscopy, without doing another test and excluding an infection. Now, next statement. Same case, and the woman comes in with an image of these skin lesions here. Now, what you see in this picture here is you see a reddish, brownish lesion on the skin of the leg. Is it tender? Is it tender? Let's see, let's feel it. Ow!
This file has been copied from www.feedyourbrain.com.
Tender, reddish, brown lesions on the leg. Well, I don't see bullae, so it can't be bullous pemphigoid. I don't see vesicles, so it can't be dermatitis herpetiformis. Great name, isn't it? It's in the form of herpes. Dermatitis herpetiform is in the form of herpes. Herpetiform is. Well, dermatitis herpetiformis is associated with about 10% of cases of celiac disease. Erythema migrans is the targety rash that you get with Lyme. There's no pale center in this lesion. No pale center. Pyoderma gangrenosum, the very word. Pyo, pus, derma, skin, gangrene. Gangrenous pus in the skin. Well, the skin's intact. It's just reddish brown and tender. That makes this erythema nodosum. Now, erythema nodosum is a localized inflammation of the skin. Paniculitis, it's called. The pannus. Where's your pannus? The pannus is subcutaneous fat. It's a bit of necrosis. Now, what causes erythema nodosum? We don't know. What do you mean we don't know? Erythema nodosum is associated with syphilis, sarcoid cocci, pregnancy, syphilis, sarcoid coccidioidomycosis, pregnancy and strep. Syphilis, sarcoid, pregnancy, cocci, and strep.
This file has been copied from www.feedyourbrain.com.
It's not the same thing. Does scaffolding cause construction? That's a stupid question. I know, I asked it. Well, is it cause it? Does scaffolding cause construction? I mean, every time I see scaffolding going up outside the building, I see construction afterwards. So does scaffolding cause construction? No, it's associated. There's a difference. There's a difference. We don't know what causes erythema nodosum. Now, the next question is, let's look at this wonderful set of 5 skin pictures. These are beautiful, aren't they? I want you to take a close look at all these because you're going to get everything you need. Wow, they're gorgeous. Choice A is gangrenous skin, necrotic skin that looks a little pussy. Choice A is pyoderma gangrenosum. Wow. Choice B with the bulla. Choice B with the bulla. Choice B with the bulla is bullous pemphigoid. Now, which is worse, pemphigus vulgaris or bullous pemphigoid? Bullous pemphigoid is better because the skin stays intact. It's dermatology. When in doubt, say biopsy and steroids. When in doubt, it's dermatology, biopsy and steroids. That's right. Now, choice C is dermatitis herpetiformis. It looks like herpes with multiple vesicular lesions, but it's up and down and all around and up and down the body. Vesicle here, vesicle there, vesicle in your underwear, everywhere. Dermatitis herpetiformis, 10% of celiac disease. Weird thing is, you could treat it with Dapsone. Wow. Wonder why. I don't know. Now, the guy with the bar in front of his eyes, like you wouldn't be able to recognize him, with the red skin lesions on his malar surface there, you might say, how do you know that that's not lupus? And the answer is, well, you couldn't really, except this one's extending up into the forehead. That red skin lesion there that's inflammatory and warm, that is simple erysipelas. Now, the word erysipelas is not a great word. You can't get a diagnosis by saying erysipelas. What does it mean? Erysipelas is a streptococcal infection of the skin. It involves the dermis, and therefore it's warm, bright, red, hot, tender. Erysipelas. Choice E. Choice E. Red on the outside, pale on the inside, red on the outside, pale on the inside. That is erythema migrans. That's the target lesion of Lyme. So the answer for this case about which we'll find is that pyoderma gangrenosum and erythema nodosum are seen in the person with inflammatory bowel. Which of them will correspond to the level of disease activity? A very important question. And the answer is the erythema nodosum will. Erythema nodosum corresponds to the level of disease activity. It's an excellent prognosis question. Next question. Same case. Lady comes in. Fever, sometimes weight loss, blood, diarrhea for a couple of weeks.
This file has been
All the
copied from
tests are negative, and she's got
www.feedyourbrain.com.
this eye finding. This is the same patient, and this is an ocular examination. So this ocular examination, let's see. Look at these multiple little white dots there. That's on the back of the cornea. These little white balls, like snow. Isn't that nice? Like we should shake the eye like the snow scene? Well, that's exactly what those are. You see, those are macrophages and epithelial cells and inflammatory material and debris stuck on the back of the cornea. Those are inflammatory cells and debris that is consistent with iritis and uveitis. The iris is inflamed, and this is the debris that floats up and hits the back of the cornea and just gets stuck and glued there. Wow. Wow. They're called keratitic granulomas or keratitic deposits. Keratitic deposits. Wow. Now, choice A, a chalazion. A chalazion is also known as a meibomian gland cyst. A meibomian gland cyst, they generally don't have any pain. Meibomian gland cysts. Conjunctivitis is not on the cornea like this. Horner's syndrome, ptosis, meiosis, which is constriction, and anhidrosis. Horner's syndrome is associated with sympathetic chain interruption for a person who has lung cancer. Optic neuritis, again, not seen on the corneal exam. Pterygium, the P is silent. A pterygium is outgrowing abnormally of the conjunctiva. It's like irritated, inflamed from the wind, from the grain of sand or grain or some sort of irritant, ultraviolet light. Pterygium, and it overgrows the cornea sometimes. It can be replaced with an amniotic fluid transplant. You could transplant, sorry, not amniotic fluid, it can be replaced with an amnion. You take a piece of an amnion. Wow, you mean like baby amnion? Well, what separates us from the reptiles? What separates us from the reptiles? An amnion. Okay, and you take a piece of it and you slap it in the eye as a transplant.
This file has been copied from www.feedyourbrain.com.
you diagnose it with a slit lamp exam. Now, this case, same case, and the question says, what is the most accurate diagnostic test for the ocular finding? And the most accurate test for the ocular finding from the Paleozoic of 4 seconds ago is a slit lamp exam. A slit lamp is basically a glorified magnifying glass. You put your chin in there, they shine a light in it, and they look through your eye at a big scope, at a magnifying glass, and just see everything at 5 or 10 times larger. It's no big deal. Dilated fundoscopic exam is how we see optic neuritis. Direct inspection on physical exam is how we see conjunctivitis or pterygium. Fluorescein staining, choice D, is how we see an abrasion or ulceration. Fluorescein is for abrasions and ulcerations. We don't ever gram stain eyes or culture eyes, and MRI has nothing to do with it. We do a slit lamp examination. Now, what is the treatment for the ocular finding here? This question is basically saying, here you have a person with uveitis. You have a person with uveitis and iritis. And the question says, what do you want to do about it? And the answer is simple: topical steroids, say, or oral steroids. Look, uveitis and iritis gives a very red, inflamed, tearing eye with photophobia. That's the single biggest key to this diagnosis, is the photophobia. When you are looking for uveitis and iritis, the big issue is the red eye with the photophobia. That's because it's the only one of them, because when the uveal tract moves and the iris constricts and dilates, it's like neck stiffness for your iris. Steroids. Cyclophosphamide is not useful at all. Mesalamine controls the underlying inflammatory bowel, but it doesn't control the uveitis and the iritis. Methotrexate is not used by gastroenterologists. Anything in gastroenterology, just don't say methotrexate, ever. There is no surgical correction for a person who's got uveitis iritis. Now, if in your pre-test you thought somebody made a mistake, and when they think about pterygium is surgically corrected. Chalazion, which is a meibomian gland cyst, can be occasionally surgically corrected, but uveitis and iritis is not surgically corrected. Topical steroids, and you look for the photophobia. Next question. Now, we changed the case now. The case is different because we're changing it to the fact that she's got jaundice, this woman with the inflammatory bowel, dark urine, jaundice. Well, there's a bilirubin. There's a bilirubin. Itching, itchy. It's the itchy and scratchy show. Why do you itch with bilirubin? Nobody knows. But any cause of liver failure and high bilirubin gives you itching. Any cause of bilirubin, high bilirubin, liver failure can cause itching. It's just part of the deal. Now, the liver is not tender. Because the liver is not tender, there goes cholangitis and cholecystitis. With the one word, non-tender, it is not ascending cholangitis. Ascending cholangitis, by definition, holy Charcot, man, fever and a shaking chill, jaundice, tenderness, fever and a shaking chill, jaundice, tenderness. That's ascending cholangitis. Ascending cholangitis is like pyelonephritis of your liver. It's E. coli crawling up from your bowel and into your liver. The same way it's like pyelonephritis. Cholecystitis, again, non-tender, it's not cholecystitis. Now, hepatocellular carcinoma is highly unlikely to be happening acutely. Is hepatocellular carcinoma associated with inflammatory bowel? The answer is no. Cholangiocarcinoma is associated with inflammatory bowel. Cancer of the biliary system, but not hepatoma. Now, hepatitis? Well, hepatitis gives you a high bilirubin, but this person has normal transaminases. There goes, can't call it hepatitis with normal transaminases, gone. This is sclerosing cholangitis because you have a high bilirubin and the signs of obstruction in the lab tests. What two enzymes
This
tell
file has been
obstruction?
copied from
Alkaline phosphatase and
www.feedyourbrain.com.
GGTP. Alkaline phosphatase and GGTP. What two enzymes tell obstruction? Alkaline phosphatase and GGTP are the two enzymes that tell obstruction. So this person has a high bilirubin, normal transaminases, there goes hepatitis. No tenderness, there goes cholecystitis and ascending cholangitis. And also, we happen to know that inflammatory bowel is clearly associated with sclerosing cholangitis. All of that inflammatory stuff coming up from the bowel, bathing the liver, fibrosing it. Is it Crohn's or ulcerative colitis with the sclerosing cholangitis? And the answer is both, as long as it's involving the colon. Next slide. What is the worst complication of the problem described in this previous question? You don't get hemochromatosis. You get cancer of the biliary system. That sclerosing cholangitis can form biliary cancer. Just as hepatitis, chronic inflammation, can cause hepatic cancer. Because you go hepatitis to cirrhosis to hepatic cancer. You can cause sclerosing cholangitis and inflammation to cholangiocarcinoma, and that's the worst thing that can happen. There is no association with hemolytic anemia, and sepsis happens generally when there's a stone or a stricture. Do you get some degree of biliary obstruction? Yes, but it's not like having a stone or a stricture. So it's remotely possible, but I think that cholangiocarcinoma is the main complication that happens in the long term with sclerosing cholangitis. Next one. What's the most accurate test for this sclerosing cholangitis? This is the only form of chronic liver inflammation that's not diagnosed with a liver biopsy. It's the only one. All the others, chronic hepatitis B and C and Wilson's and hemochromatosis and primary biliary cirrhosis, they're all diagnosed with a liver biopsy. And this one is ERCP. The endoscopic retrograde cholangiopancreatography will show you beading and narrowing and fibrosis of the biliary system. So ERCP is the most accurate test. Now, antimitochondrial antibody is the test for primary biliary cirrhosis. Antinuclear cytoplasmic antibody, also known as an ANCA. Well, you get ANCA in people who have ulcerative colitis. However, it's totally nonspecific. You know, it doesn't tell you got sclerosing cholangitis just because you have ANCA. Anti-smooth muscle antibody. People always get those confused. I'm sorry, smooth muscle, mitochondrial. Anti-smooth muscle is autoimmune hepatitis, which is the same as the liver-kidney microsomal antibodies. Wow, it's a lot of names to remember. Anti-smooth muscle and liver-kidney microsomal go along with autoimmune hepatitis. Used to be called leukoid hepatitis. Give me an ANA, treat with steroids. Autoimmune, autoimmune. Anti-smooth muscle, liver-kidney microsomal, ANA, treat with steroids. Thank you. Sclerosing cholangitis is diagnosed with an ERCP, and it's treated with urso and chenodeoxycholic acid. Urso and chenodeoxycholic acid, which block the production of bile, and cholestyramine, which bind bile in the gut. Next one. Which of the following is the most consistent with ulcerative colitis? Now look, this is a way of asking you, do you understand some fine points of diagnosing inflammatory bowel disease from blood testing? They're not going to ask you whether you understand that Crohn's disease has skip lesions. It's like the only thing you do know. They're not going to ask you about whether you know that ulcerative colitis is limited to the colon and that ulcerative colitis causes colon cancer, because ulcerative colitis causes colon cancer, and you know that part. But these things are because sometimes you have inflammatory bowel that's hard to reach and hard to see. And sometimes it can be hard to distinguish them. Not that it makes that much of a difference in treatment. It happens to be that people with ulcerative colitis have an ANCA positive, anti-neutrophil cytoplasmic antibody positive, ANCA positive, and Saccharomyces cerevisiae negative, choice B. It happens to be that ulcerative colitis is ANCA positive, cerevisiae negative, and Crohn's is the opposite. Don't get HLA-B27 as most accurate for anything. 8% of the population is HLA-B27 positive. And it's true that HLA-B27 is associated with people with axial skeleton disease, but it's completely nonspecific. Someone has ankylosing spondylitis, don't say B27 first. Say X-ray of the sacroiliac joints. Don't go for HLA-B27 first for anything. C-reactive protein, I could get a parking ticket today, and my C-reactive protein would be up. Okay? That's totally nonspecific. The same with the SED rate. Okay? The same with the SED rate. Serve me a crappy salad at lunch, my sedimentation rate can go up. C-reactive protein, step on my toe, and my C-reactive protein goes up. Totally nonspecific. Ulcerative colitis is ANCA positive and anti-Saccharomyces cerevisiae. Saccharomyces? The bug that makes the beer again? These things in colon stuff and Crohn's disease has an antibody against the organism that ferments beer? You got a beer producing organism in your rectum? Why do you get ANCA positive and anti-Saccharomyces cerevisiae negative in ulcerative colitis, and the opposite is true in Crohn's, is not known. Why you even get an antibody against Saccharomyces cerevisiae, period, in Crohn's, not known. It's the organism that ferments a beer. Why it's there, go get your Nobel Prize, figure it out. Now, let's look at these beautiful, pictures of the family portrait here. Look at these 5 beautiful pictures of the colon. Oh my goodness. Oh, one type of disease, 2 different antibodies, 5 colon pictures. Here we go again. Oh, look at these. Well, which one are you going to find on colonoscopy in this patient? Choice A is a polyp. Look at A, it's a polyp. Flesh colored, no breakdown, needs to be biopsied and removed. Do you know that thing will take 10 years to look into the picture and see? Picture A is a polyp. Picture C is colon cancer. I think it's amazing that it takes 10 years to get there. You have 10 years of a window of time to get into that colon and snare that sucker, lasso down. Yeah! Woo! Look at that. Ooh, got a live one there. Oh, yeah! Okay? Grab that polyp, lasso it up, and pull it on out. Yeehaw! Before it becomes that colon cancer in C. Now, answer B is the answer. You see that lumpy, bumpy thing? Those little bumpy? That kind of looks like, I don't know, it kind of looks like cobblestones on a street. You know what that's called? Cobblestoning. And that cobblestoning there is a classic for Crohn's disease and inflammatory bowel. Choice D, where it looks like holes in there, is that choice D is diverticulosis. And when you see the big O's, it's diverticulosis, when you see the big O's. And that just happens. That's what you get from having a bacon cheeseburger, low fiber, high fat, disgusting American diet, bad Hindu, bad vegetarian. Ganesha is going to kick your boop, give you diverticulosis. Choice D. And choice E. Look at that. Choice E. Why, it looks so, you know, choice E. I wish my apartment could be half as clean as choice E. Look at this. Clean, nice, well-ordered, beautiful, well-lit, smooth, shiny, no dirt. It's a normal colon. Yes, choice E is a normal. Hold it. Wait, can you pause it, because I'm having a moment with choice E here. It looks so clean and fresh and unadorned. And the reason why choice E is so important for you is because it helps you know by comparison that A is the polyp and B is cobblestoning and C as in cancer, that C, choice C as in cancer, is cancer. Look on the bright side, 95% of it's preventable. 95% of it is preventable. Actually, this brings up an extremely important question, which is, which one it puts you at risk for colon cancer? Crohn's or ulcerative colitis? The answer is both. The answer is both of them put you at risk for ulcerative colitis. Both of them put you at risk for ulcerative colitis. Okay? Now, also the other big question is, after how long should you screen before you have to go do colonoscopy to look for colon cancer with these inflammatory bowels? And the answer is, after 8 to 10 years of inflammatory bowel involving the colon, you screen for colon cancer. After 8 to 10 years of inflammatory bowel involving the colon, you screen for colon cancer. That's an important question. It's important because the question, that's a general question, which is, you don't have to know every fine point of inflammatory bowel if you're a general internist, but you should know at least when to start screening for that colonoscopy. 8 to 10 years, and both Crohn's and ulcerative colitis can do it. Now, this picture here in this next slide, showing 2 photomicrographs, is informational. And these 2 pictures side by side show, well, it's labeled there. And one is basically showing you the circular whorl of granulomas and showing you that Crohn's disease has a transmural granuloma. And ulcerative colitis has some cryptabscesses. But we don't do much about cryptabscesses in ulcerative colitis. But the transmural granuloma in Crohn's has enormous significance, because it's part of the reason why you can get more bleeding, more weight loss, more fever, and why you can actually perforate with Crohn's disease. You don't perforate with ulcerative colitis. That's a big deal. Next one. Which of the following is the greatest point of difference between Crohn's and ulcerative colitis? What's the single point of difference? Which one puts you at risk for cancer? Both. That's a really important question. It's in there twice for that. They both put you at risk of colon cancer. If you have Crohn's that involves your colon for 10 years and ulcerative colitis that involves your colon for 10 years, you have the same risk of cancer. Es igual. Eye involvement, uveitis. They both have uveitis. They both have arthritis. Nope, they don't both have rectal involvement. That's the big difference. Crohn's spares the rectum. Crohn's has transmural granulomas. And ulcerative colitis can be cured, because you can't have colitis if you don't have a colon. So we can take out your colon and cure your colitis. Crohn's can never be cured. The greatest point of difference is the presence of rectal sparing. Crohn's spares the rectum. Next one. We have a 24-year-old woman, same person. The patient improves. She's getting better. What do you do for maintenance? What do you do for maintenance in inflammatory bowel disease? What do you do for maintenance? And for maintenance, the first drug of choice is mesalamine. Why not sulfasalazine? Because sulfa gives you lots of rashes. It gives you lots of hemolytic anemia from sulfa. It gives you lots of Stevens-Johnson from sulfa. It gives you hemolysis from sulfa. It makes you urinate eosinophils from sulfa. Sulfasalazine gives a lot of abnormalities because of the sulfa. But it doesn't give more efficacy than mesalamine. Mesalamine does all the efficacy and more with none of the adverse effect of sulfasalazine. Osalazine is an old 5-ASA derivative that's rarely used, but it is not a better 5-ASA derivative than mesalamine. The top 3, cyclosporin, 6-mercaptopurine, azathioprine, are 3 alternate drugs that can be used to keep people off of steroids in the long term. But the drug of choice initially is mesalamine. Some of you may know it as Asacol, ASA for the colon, Roasa, rectal ASA, Pentasa, which is for Crohn's disease, Pent-5-ASA, ASA, Pent-ASA. Cute, right? Mesalamine has several delivery forms. Roasa, Pentasa, Asacol. Several versions, but they're all mesalamine. Best initial therapy for maintaining people. Next slide. Now the next slide says the Crohn's lady is coming in with a foul smell to her urine. Urine's dark. She's got burning and frequency, urgency, burning dysuria, frequency, urgency, burning dysuria. The urine's dark and the urine smell, and she's starting to pass poo-poo through her urine. Well, this is the big issue, is that Crohn's disease can put fistulas through the different organisms. Through the different organs. Ulcerative colitis can't. It's all mucosal. But Crohn's disease can put a fistula to your bladder, which is what this is. Recto to vesicular fistula. Rectocutaneous comes right out through your skin. You start pooping through your anterior abdominal wall.
This file has been copied from www.feedyourbrain.com.
Transmural granuloma. Yeah, that's what this is. You think your social life has problems sometimes? You think that you have difficult things to confront with in your personal life? How'd you like this one, you know? Hi, we've been together for a while now, and I think there's something I need to tell you about myself. Oh my God, Conrad, you're still married? No, I'm not married. I have a rectocutaneous fistula. Oh. I kind of wish you were just still married. You can kind of fix the marriage right overnight. So rectocutaneous fistula is a lot harder to explain. Okay? So the reason why this is such an important issue, though, not to get upset, not to despair, not to say Dr. Fish is making fun of people with rectocutaneous fistulas, it's to set you up for the drama of the next slide. What must be done prior to beginning the treatment to the drug of choice for fistulas? And the answer is planting a PPD. Because infliximab and TNF inhibitors will close up that fistula. Wow. Infliximab, TNF, tumor necrosis factor inhibitors, will close up that fistula. And the only reason we make all that drama before is to set you up to understand that if you have these horrible, horrible complications, which you can't do surgery on because it recurs at the site of the surgery. Do you understand what that's like? What a miracle that is. You could take someone whose life is total crap. I've seen it, you know, rectocutaneous and rectovaginal fistulas, miserable people, and the infliximab closes them up, man. Oh, yeah. But you got to plant the PPD because granulomas are formed by tumor necrosis factor. They hold them together in glue. And the granulomas wall off the TB. Now, sometimes the TB is all the way dead. Sometimes it's just imprisoned out of time and space in a granuloma. And the infliximab can unlock it. Now, it doesn't mean you can't use the infliximab. It just means you've got to give them isoniazid if the PPD is positive. I get these people like this. Oh, so you can't use infliximab if the PPD is positive. It's like, you know what? It makes me crazy when people ask me this question. Can you imagine this one? Oh, yeah, that's it, because no, you can't use the infliximab because if your PPD is positive, I mean, I'd just rather keep having bowel movements through 3 anuses, right? I'll tell you what, I'd take 2 tuberculoses to be able to have the chance to close up a fistula. So I get asked every month, does that mean you can't use infliximab? No, it just means give the INH. What do you do? Sorry, I'm going to leave you at your rectovaginal fistula because you might have TB. Well, TB is a walk in the park, you know what I mean? If you don't get the same emotional charge out of TB as they do out of various forms of holes in them. You ever been around a colostomy bag that broke open accidentally? Don't. Matter of fact, it makes me uncomfortable just to think about it. Close off the fistulas. Close off the fistulas. Reminds me of Walt Whitman. Unscrew the locks from the doors. Unscrew the locks from the doors. Unscrew the doors themselves from the jambs. By God, I will have part of nothing which my fellow man cannot have his equal part of. Unscrew the locks from the doors. Unscrew the doors themselves from the jambs. Yeah, well, you know, give me tuberculosis. Give me 2 tuberculosis. Just give me the infliximab and close up my fistula. Your big association is this. Infliximab can reactivate tuberculosis. Because TB is often not killed. It's imprisoned out of time and space. When Zeus and his brothers and sisters conquered the Greek gods and the Titans.
This file has been copied from www.feedyourbrain.com.
They took them and brought them out of time and space and imprisoned them outside of time and space in Tartarus, where they're there apparently forever and ever, out of time and space. And what this is a granuloma, is like the imprisonment of the Titans in Tartarus out of time and space. And they can come back if you unlock the doors. Okay. Next question. 24-year-old person with a history of Crohn's disease, not controlled with mesaladine and budesonide. Now let's look at this budesonide. Budesonide is a steroid. Budesonide is used for people whose inflammatory bowel is not controlled with mesalamine. It's very similar to this. If you have a person with asthma, you use inhaled beta agonists. And if the inhaled beta agonist doesn't work, you use inhaled steroids to control it as an anti-inflammatory. Well, Crohn's disease, you use mesalamine. It was like albuterol for your guts. And if the mesalamine doesn't control it, you use a special, although it's oral, budesonide has an effect locally in the small bowel, but has no systemic effects because it has first pass effect. It goes into the liver, and the liver detoxifies it and gets rid of it. Now, if you had asthma, or you had temporal arteritis, or you had some other problem where you needed systemic effect of steroids, that'd be a disaster because you'd be like giving the steroids and they get all detoxified. But budesonide has an effect inside the guts, and then when the blood supply goes out of the guts and into the liver, because remember, 2/3 of the blood supply of the liver is out of portal circulation, veins from the guts. It has an effect topically, locally inside your guts. It's like a cream for your intestines. And it gets detoxified inside your liver. And there's no systemic effects, so very limited. First pass effect, budesonide. Fantastic. So if you're not controlled with mesalamine and budesonide, we have to use an alternate, an additional form of immunosuppressive. And out of this collection, azathioprine is the choice. Now, azathioprine is essentially metabolized to 6-mercaptopurine, essentially the same drug. So azathioprine and 6-mercaptopurine are interchangeable, and they help keep you off of steroids, and they help control you if steroids, the topical steroids, like the budesonide, the steroids inside your gut, won't work. Azathioprine. Busulfan is an old drug for leukemia, and it exists only as a wrong choice on board tests, or when it says which of the following is most likely to produce pulmonary fibrosis. Methotrexate is not used in gastroenterology. Azathioprine is an alternative form of immunosuppressive. Our final question for inflammatory bowel disease. Our last slide in inflammatory bowel. And this question says, you're on mesalamine, you're on budesonide, you're on 6-mercaptopurine, you're not controlled. What are you going to do? There's no point in adding azathioprine to 6-mercaptopurine. They're the same drug. Chlorambucil is the CLL. You can't do colectomy for a person who's got disease in their small bowel. Methotrexate is useless in inflammatory bowel. Did you know that ciprofloxacin and metronidazole can control Crohn's? Really? Yes. Did you know that ciprofloxacin and metronidazole, which are the drugs of choice for diverticulitis, can control Crohn's? Yep, particularly where it says there is disease activity in the perianal area. You can use ciprofloxacin and metronidazole to control it, and that's the answer. Inflammatory bowel. Now, there's a lot of different diseases in here. So basically it goes like this. There's no difference between Crohn's and ulcerative colitis in the extraintestinal manifestations. Skin, joint, liver, eye, skin, joint, liver, eye, no difference in those. 5 ASA derivatives such as mesalamine are the best initial therapy for both of them. You use steroids for acute exacerbations. However, in long-term maintenance, we want to get you off of steroids. We use azathioprine or 6-mercaptopurine to get you off of steroids. If there's fistulas, we use infliximab. If you've had colonic involvement for greater than 8 to 10 years, we should be screening you for colon cancer. The extraintestinal manifestation that correlates with disease activity is erythema nodosum. It's erythema nodosum that correlates with disease activity. And before you use infliximab, you must screen for PPD to make sure you don't reactivate tuberculosis. If you said, fishy, I only want to learn one question for inflammatory bowel, I would say the association between infliximab and the reactivation of tuberculosis. Not that you wouldn't use the infliximab. You'll use it. Just test and treat for latent tuberculosis. Thank you very much. Thank you very much. Thank you very much.
Put your back on your shoulder. Be the good